Alright, y'all, here's another long one, but it's for my researcher friends. It's an article review. This is one of my more favorite articles that I've found. It was in the Journal of Pain Research. Alrighty, this is from my friends over in Belgium. Louvain, Belgium. It's the link between idiopathic intracranial hypertension, fibromyalgia, and chronic fatigue syndrome, exploration of a shared pathophysiology, by Dove Press, something in hypothesis. This is great, y'all. This is a really good article. I actually kind of like what they did. So it goes over their purpose. Idiopathic intracranial hypertension is a condition characterized by raised intracranial pressure. Diagnosis is established when the opening pressure measured during lumbar puncture is elevated greater than 20 in non-obese patients. Ooh, wonder where they got that one. Or 25 in obese patients. It does say that papilledema is caused by forced filling of the optic nerve sheath with cerebrospinal fluid. Other common but underappreciated symptoms are neck pain, back pain, and radicular pain in the arms and legs, resulting from associated increased spinal pressure and forced filling of the spinal nerves with CSF. I don't know where they're getting this, but this is beautiful, because this is what's been happening to me. Widespread pain and also several other characteristics of IICH, which is what they're using as an abbreviation, share notable similarities with the characteristics of fibromyalgia and chronic fatigue syndrome, which is fibromyalgia they're calling FM, and chronic fatigue syndrome they're calling CFS, two overlapping chronic pain conditions. Notice this is in the Journal of Pain Research. Sorry, don't know if you can see that. There we go. All right, so their conclusion was that IICH, FM, and CFS share a large variety of symptoms that might all be explained by the same pathophysiology of increased cerebral spinal pressure. Wait a minute. So in this, what they're trying to say is, if you have a patient with fibromyalgia or chronic fatigue syndrome, do not overlook the possibility that they might have increased intracranial pressure. Don't just shove them right out the door. Try to actually see if that might be one of the problems. Whoa. So the pathological mechanisms that cause both fibromyalgia and chronic fatigue syndrome are incompletely understood. FM and CFS share very similar symptoms with idiopathic intracranial hypertension, a condition characterized by increase in intracranial pressure due to unknown cause. And the authors reviewed the literature to explore these common symptoms and to link them to the hypothesis. Is this a hypothesis? Okay, people, they're not proving anything. They're just looking at literature and saying, oh my gosh, might there be a link? Do these pain management doctors need to explore a little bit further if somebody's having fibromyalgia or chronic fatigue, that maybe there's something else going on, and they need to explore if it might be something going on with the intracranial pressure. So they actually did a really, really good job looking at a lot of literature. Okay, lots of literature in this article. And it's a beautiful article because it's for pain management, for pain management doctors. Okay, so hold on, sorry. The authors reviewed the literature to explore these common symptoms and to link them to the hypothesis that increasing intracranial pressure and spinal fluid pressure is a possible mechanism that initiates the multitude of symptoms in these. Sorry, gotta go to the next page. Yep. In these conditions, the symptoms include neck pain, back pain, pain in the arms and legs, numbness, tingling, headaches, fatigue, cognitive impairment, gradual loss of gray matter. In addition to symptoms involving cranial nerves, overload of the lymphatic system in the nasal mucosa, Disturbance of the autonomic nervous system. Other shared characteristics include higher frequency in females and family members, and an association with obesity and Ehlers-Danlos syndrome, a connective tissue disorder, which stinks, which I don't have, but some people do have, which is a whole nother disorder, and I hope somebody else has a channel on that because that is just not fun. These findings are relevant as they provide an alternative hypothesis concerning the pathological mechanisms in FM, fibromyalgia, and CFS, chronic fatigue syndrome. Okay, so it does go over a lot of the symptoms associated with increased intracranial pressure, the headache, the fatigue, the cognitive impairment, and it goes over the hypothesis. There's a beautiful table. The hypothesis, the signs and symptoms, what happens in intracranial hypertension, fibromyalgia, and CFS. It's a beautiful, like this huge table. Okay, so the hypothesis, what happens in the first column, signs and symptoms, intracranial FM, and then CFS. It's gorgeous how they go through it. And they go through the cranial nerve involvements, increasing intracranial pressure, the migraines. This is a great article. I mean, if you do pain management and you are involved with anybody that has the fibromyalgia, the intracranial pressure, chronic fatigue even, you should definitely take a look at this. But it even goes over the cranial nerves. And just, wow. Okay. Migraines. Let's see here. Signs and symptoms of migraines. 70% of unresponsive migraine patients have IICH, and fibromyalgia, 55% of migraines, and chronic fatigue, 84% of migraines. The fatigue, common in IICH, of course, symptoms in fibromyalgia, CSF, of course, this is a core symptom. Cognitive impairment, across the board. Loss of gray matter, well, not in IICH, but it's 3.3-fold greater age-associated decrease in fibromyalgia, and regional gray and white matter volume reduction in chronic fatigue syndrome. It goes over the nerves, the optic nerve, the olfactory nerve. Anyway, it goes over all these different things. Something I found very interesting. Where does it say? Sleep disorder. Oh, miscellaneous. Oh, the disability part. That's not fun. Oh, walking difficulties and ataxia. 12.2% in IICH. 26% have it in FM. 63% have poor balance in FM. And definitely in chronic fatigue syndrome, and reduced gait automaticity in chronic fatigue syndrome. So that's also across the board. Weakness in the arms and legs, 69% in IICH, 58% in FM, and muscle weakness and fasciculations in chronic fatigue syndrome. Let's see here. Maybe it's back with the olfactory nerve. There's one about sinus issues. Oh, sinusitis, which I have. I've had to have the surgery going through and digging out my sinuses. Oh yeah, olfactory lymphatic pathway. Signs and symptoms. Evacuation of CSF via the lamina cribriformis to the lymphatic vessels of the nasal mucosa. So in IICH, you get a lot of sinusitis, or sometimes you get spontaneous CSF leak with rhinorrhea. A lot of sinusitis, right? In FM, there's a whole bunch of non-allergic rhinitis, 46%. And then in chronic fatigue syndrome, you get idiopathic non-allergic rhinitis is highly prevalent in chronic fatigue syndrome. Just going over that part of this article. Found that interesting. Oh, and this is beautiful. It actually goes over nerve by nerve. Isn't that gorgeous? This is gorgeous. This is a gorgeous table. Overview of the interactions of ICP with the nerves presented in this paper, the olfactory lymphatic pathway in the inner ear, abbreviations, CSF, cerebral sinus, but it goes over ICP and what it does to your, I don't even know where they got this, but ICP and the different nerves. Decreased olfactory bulb volumes, visual field constriction, retinal nerve fiber thinning, sensory trigeminal neuropathy, corneal pain, decreased corneal small fiber density, masticulatory pain, temporomandibular disorders, TMJ, which I have. Brainstem, sympathetic activity predominance. Does that mean night sweats? Because I have really bad night sweats. Small fiber neuropathy may be caused by axonal damage of the afferent sensory nerves. Increased CSF pressure in inner ear, vertigo, tinnitus, oral fullness, tinnitus. Yes, lots of tinnitus. Motor facial muscle weakness, parasympathetic racemal, salivary gland dysfunction, dry eyes and dry mouth. Dry eyes for sure. Vestibular dysfunction, hearing loss. Visceromotor, slow gastric emptying. Great. Radicular pain, numbness, and paresthesia. Subjective and objective muscle weakness, fasciculations. Loss of muscle mass, sensory ataxia. Irritable bowel and bladder, sphincter dysfunction. Great. Overview of interactions of ICP with all of the nerves presented in this paper. Lovely. That's lovely. Sympathetic activity predominance. Huh. Anyhow. There's a picture of a dilated optic nerve of a patient with visual field deficits and unexplained widespread pain. Beautiful picture right there. I do not have that, thank God. But it does talk about the ocular nerve, trochlear nerve, and abducens nerve. The function of the eye muscles. They cause ocular motor weakness, double vision, and even ocular motor palsy. But my nerves just hurt. It goes over the facial nerves. It goes like nerve by nerve. Nerve by nerve. Olfactory lymphatic pathway. As previously mentioned, CSF drainage routes involve the flow of CSF along the perineural space of the cranial nerves. Most common pathway involves the olfactory nerve, the fibers of which leave the olfactory bulb, penetrate through the foramina of the cribriform plate to leave the brain. The endothelial layer of the olfactory nerve sheath becomes thinner in the nasal mucosa covering the conchae, nasal septum, ethmoid sinus, and lateral walls of the nasal cavity. Subsequently, CSF penetrates through the endothelium into the lymphatic pathways of the nasal submucosa toward the regional lymph nodes. In patients with IICH, several cases of sinusitis have been reported. Masri reported that 5 of 19 children with IICH had sinusitis. In patients with severely increased CSP, a spontaneous dural leak through the thin layer of olfactory nerve root sheath may cause rhinorrhea. In patients with FM, fibromyalgia, and those with CFS, chronic fatigue syndrome, idiopathic non-allergic rhinitis is a common symptom and presents as nasal obstruction and rhinorrhea. According to this hypothesis, now of course they're linking the symptoms, obstruction of the nose and rhinorrhea may occur when olfactory lymphatic drainage becomes saturated by excess CSF. So they're trying to link those things, but it's kind of interesting to see. Symptoms associated with increased spinal pressure, spinal nerves. Now they're going over that, spinal nerves. This one's interesting because ataxia has always been one of my issues. Sacral nerve root sheath dilations can be observed, and these appear to be very similar to the optic nerve root sheath dilations. A more lateral view of the sacrum showing significant dilation of nerve root S3. And they show pictures. See? Pictures. So it does show how you can have ataxia, and poor balance with the sacral nerve root sheath dilations, because the CSF goes down into your sacral nerve root and makes it big and squishes against your nerves and makes it hard to walk because your nerves don't feel right, which is what happened right after I got home. Anyways, so in patients with FM and those with CFS, sensory ataxia due to damage of the afferent fibers carrying the proprioceptive information from the legs, ataxia and poor balance in patients with FM, and reduced gait automaticity in patients with CFS have been reported. So they're trying again to make the link based on the symptomology for fibromyalgia and chronic fatigue syndrome, because the symptoms are very, very similar. And don't get me wrong, before they made my diagnosis, when they were saying, hey, you're having migraines for like 2 years straight, they still, at one point, wanted to say I also had fibromyalgia. At one point. They wanted to say it. I would not let the words cross their mouth. But I was also very, very, very tired. So at one point, they also wanted to say, oh, you have chronic fatigue. I would not let those words cross the doctor's mouth. I would not let them write it down on paper. They just put migraines and ataxia until somebody finally stuck a needle in my back and the numbers came back and they said, oh, it's not migraines. You have intracranial hypertension. After I pushed and pushed and pushed and pushed. But this paper that I'm reviewing is linked in those symptomologies. So I'm doing this review so that doctors and other people who are looking at me doing this review can look at these symptomologies and say, oh, maybe that patient with fibromyalgia that's also saying they have a severe headache, that's also saying they have all these other issues, maybe we should look at some more tests and some more things. All right, on to the next thing. Sympathetic activity predominance. Sympathetic nervous system prepares the body to fight or flight. The symptoms include the following: digestive problems, slower gastric emptying, constipation, superficial breathing, tachycardia, postural hypotension, anxiety, night sweats, poor sleep quality, obstructive sleep apnea, and fatigue. Well, the fatigue I thought was from my brain getting squished, but night sweats. What about hot flashes? Is that in there? Use of muscle microneurography to assess sympathetic activity showed that a 9 centimeter H2O ICP increase from 11 to 20 significantly increased sympathetic activity by 17%. This is probably due to pressure-sensitive receptors in the brainstem that have the potential to trigger a sympathetically mediated systemic response. Wow. They did do their research. A systemic review revealed that 60% of studies on FM and CFS describe sympathetic activity predominance in these conditions. The most frequently used methods to assess sympathetic function were heart rate variability analysis, tilt table testing, sympathetic skin response, and genetic studies. Genetic origin. Well, patients suffering from IICH, FM, and CFS are significantly predominantly female. Strong indication of family inheritance. Patients with connective tissue disorders such as Ehlers-Danlos syndrome. Increased risk of developing one of these three conditions may indicate that genetic defects may play a role in ICP dysregulation. Obesity. IICH is mostly diagnosed in obese female patients. Depression, anxiety, poor quality of life. Well known that FM and CFS patients suffer from depression, anxiety, and poor quality of life. No, well, I mean, that wasn't me, but I guess sometimes the one could do the other. I guess if you're constantly, like, feeling like you're depressed, feeling like you're doing the fight or flight thing, it can push you into the dysregulation. Like, cart and horse or chicken and egg. If you're always in the sympathetic response cycle, maybe they could push you into it. That might be worth studying. Like females in combat zones. Or females with PTSD. Huh. Anyways. Sleep disturbances among FM patients, 70% were found to suffer from a sleep disorder. Among adolescent patients with CFS, 69% were found to suffer with one or more sleep disorders, and 82% of patients with IICH may suffer from sleep disturbances. Well, yeah. And of course, disability. Additionally, as in patients with FM, those with CFS, patients with IICH have a high rate of disability. Well, it's kind of sucks. Yeah, it's not easy to go about life with this. Anyways. The role of cerebral blood flow in the pathophysiology of IICH, FM, and CFS. Excuse me. Although the pathophysiology of IICH is unknown, growing evidence suggests that cerebral venous outflow obstruction due to transverse sinus stenosis may be the underlying cause. Yet they've already checked that on me, though. But that it can be a cause. Bilateral transverse stenosis can be identified on MRI in more than 90% of patients with IICH and only 3% of healthy controls. That was me. Stenting was applied as a management strategy with and without papilledema, resolving condition in all papilledema patients. Yeah, there was a study that it did resolve a lot of people. It talked about CFS patients often present with orthostatic intolerance syndromes, such as blurred vision. Using quantitative flow MRI techniques, it was demonstrated that CFS patients were more severe orthostatic intolerance syndromes, exhibited higher levels of cerebral perfusion and lower levels of intracranial compliance. Cerebral compliance represents the ability to buffer increase in cranial volume while preventing the rise of ICP. So IICH, FM, and CFS share very similar characteristics and are probably caused by the same underlying disorder of increased CSP. IICH, FM, and CFS can be considered progressive neurologic disorders affecting the central and peripheral nervous systems. This hypothesis may also provide an explanation for several overlapping chronic pain conditions. These include FM, CFS, temporal mandibular disorders, irritable bowel syndrome, chronic tension, headache, chronic migraines, severe dry eyes, and chronic nonspecific low back pain. Unraveling the pathophysiology of FM and CFS is important for the recognition of the suffering of patients with these disorders, as there is a stigma associated with the diagnosis of FM or CFS. Moreover, future research should probably focus on therapeutic strategies to lower CSF pressure. So their hypothesis is kind of based on the fact that there is IICH, which we know that it is characterized by poor quality of life. Right there, characterized by poor quality of life and headaches. And it says it right there. And it's true. But it's measurable. And I think that that's what they're concluding, is that there's this stigma for fibromyalgia or chronic fatigue syndrome. And it's a lot of times it feels like the doctor's just pushing you off, saying, oh, you hurt. And that's all I'm going to say is you hurt. Here's some drugs because you hurt. And they're not going to try to keep trying to figure out why. Why do I hurt? Help me figure out why I hurt so I can stop hurting so I can go about my life. And that's a lot of times what we want. We just want to have our life back. When you have a painful condition and you go to a doctor, you're not just saying, I want drugs. A lot of times you're saying, fix me so I can have my life back, please. And they say, oh, well, you have chronic fatigue syndrome. What the heck is that? No, I don't want just a handful of drugs. or some piece of paper saying I can't work. I want to work. I want to enjoy my life. I want my life back. And so this paper is really nice because it's saying, oh, hey, no, there is a possible very close link between those two things and idiopathic intracranial hypertension. Now, don't get me wrong, idiopathic, we don't know what caused that, but at least we know what that is. It's an increased pressure around the brain and the spine from the CSF. And look, we have pictures of it causing issues around the eyeballs. Look, we have pictures of it causing issues around the nerve that helps you walk. It is backfilling around that nerve, and it's backfilling down into the sinuses. And we're describing how it gets down into the sinuses and causes the sinusitis, and why you had to have the sinus surgery because you have this increased pressure. Is in here. The research is in here. So let me give this credit here. It's Mikey, Hulens, Ricky, Rasscharrt, Greet, Vansant, Ingeborg, Stalmans, Franz, I'm killing them, Bruyninckx, and Wim Dankaerts. Okay. Anyways, they're in Belgium, and they write for the Journal of Pain Research, and okay, here they are. I'm going to give credit where credit is due. Here are those lovely, wonderful people. I'm going to put it all down into the comments, and hopefully I'll find a DOI on this thing somewhere. If not, I'll just put all the information, because this is a wonderful article for anybody doing any kind of pain management stuff. And of course, they have links. They have, their references are great references to go ahead and go find more information about these 3 different conditions. And again, it's a hypothesis. They're looking at all these different things, and they're trying to hypothesize that there might be a link. So they're saying, hey, what? Do research. Let's open this door and see where these floodgates might lead. So somebody else, please, keep looking and keep trying to help people like me and people who have the fibromyalgia and who have the chronic fatigue. And, research and see if there is that link and if they can be helped also.